Outside, I'd like to thank Karthik and Sasi for inviting me here. I'm enjoying these sessions since yesterday. So Abhishek has made my job easier. He's set the platform how you approach a patient who has had hypercalcemia and hyperparathyroidism. What are the localization studies which normally should be done, and the success rate of surgery in the hands of parathyroid surgeons is almost 98%. And yet there are 2% patients that there is a failure. But this percentage can vary. In inexperienced hands, the failure rate can be as high as 40%. So there are situations where, despite your localization, despite a confirmed diagnosis of hyperparathyroidism, you do get failures. And let's see in next 20-30 minutes what are these situations and how you can prevent or how you manage these situations. So I've divided my talk into sort of 4 segments. I'll talk about the causes of the persistent hyperpara. Then what are the predictive factors? Can we really predict which patient is likely to land up with a failure? And can we prevent these kind of failures? And if we do get failures, how we do a re-operative parathyroid surgery, which requires some special tips and tricks to avoid complications which are associated with any kind of re-surgery like parathyroidectomy or parathyroidectomy. So, as I said, I've divided my talk into these 4 segments. So this is a typical patient that we get in this part of the world with very severe bone disease, a young patient with femur fracture. Femur is the strongest bone in the body and requires a lot of force on a RTA to get fractures. But hyperpara is the only disease where you get femur fracture after a trivial trauma. So you do a biochemical diagnosis and then you localize, as Abhishek rightly mentioned, with an ultrasound, with a MEB, and either you do a bilateral exploration, which is gold standard, or you do a focused parathyroidectomy where you give a very small incision and you remove just the pathologically involved parathyroid gland. So if there's a single adenoma, you remove that offending adenoma. If there is hyperplasia, you would do a 3.5 gland or a near total parathyroidectomy. And as I mentioned, the success rate is 98%. And yet, you do get failed parathyroidectomy, sometimes in experienced hands as well, but mostly in the inexperienced hands. Now, just to give you a historical perspective, this is a very interesting case of Captain Charles Martin, and this was the most notable case of hyperpara in America. And interestingly, he underwent 6 neck operations without success because the parathyroid gland was lying in the mediastinum. So the first parathyroid case in America was actually an ectopic parathyroid gland, and it was a case of re-operative surgery. And unfortunately, he died later when he was getting his ureteric stone removed. So this is, as Abhishek said, a fun fact for you. Now let's see what are the causes of the failed parathyroidectomy. The most important is the inexperience of the surgeon. So the most common cause is the surgeon inexperience, and the most common cause is that the surgeon is unable to find the parathyroid adenoma in a normal location. So generally we think that the parathyroid must be lying ectopically, and that is why the surgeon could not remove it. But in the literature, it is found that the adenoma was actually in the normal location, but because of the inexperience, the surgeon was not able to find it intraoperatively. So just a case of 46-year-old lady who typically had all the symptoms of hyperpara, and the surgeon operated on her, but she had persistent hypercalcemia and hyperparathyroidism. These are very nice notes given by the surgeon. The trick is that always look at the pathology report, that's very important. And here you see the container which was labeled as a normal parathyroid gland, there is no tissue. Container which is labeled as parathyroid adenoma shows no tissue at all. So there was no parathyroid tissue in the. So you cannot hide anything from a pathologist. So pathologist tells you, has all the secrets of the surgeons. So we did a MEB scan and we found that there was a big adenoma lying here, right inferior adenoma. We also did a CT scan, 4D CT, and you see the big adenoma is lying there. This is a patient who was operated for hyperparathyroidism. So we went in and operated on the patient. We found a large adenoma, just 3 centimeters. We had a good fall of the IOPTH, and this is the adenoma. So this is the thyroid gland, and this is the big adenoma. So the trick actually is that you have to really mobilize the thyroid gland. If you don't mobilize your thyroid gland, the parathyroid gland is within the fascia behind the thyroid gland. And if you just, sort of play around with the thyroid and don't mobilize it, you will not see the parathyroid gland. So that's the trick that has to be utilized, and I will dwell on it a bit later. The second most important cause is when you have inappropriately resected, which is actually a case of multiple gland disease, but you thought that it is a single adenoma, and you resected it, and the patient continued to have hyperparathyroidism. And the commonest situation that we have is patient of MEN1. So MEN patient, you do a localizing study, you find an adenoma which is nicely localized on a MEB scan. You went in and you removed it, and then later on realized that the patient had all the telltales of MEN1 and you missed it. So I'll just illustrate by a case. This was a 40-year-old lady who presented with body ache, weakness, recurrent fractures. But the thing that was missed by the surgeon was she had small collagenomas on the skin which are present all over the abdominal wall, and that's a telltale sign for a MEN1 patient, which is missed by the clinician. She had nephrocalcinosis, elevated calcium in PTH levels. The sestemibian ultrasound showed a concordant parathyroid adenoma on the left side. The surgeon went and did a focused parathyroidectomy. It was biopsy, of course, it was a parathyroid tissue, but the patient continued to have hypercalcemia. The PTH was high, the calcium was 11.4. So we did all these studies and we found that on the 4D CT scan, she had 2 adenomas, right superior and left inferior. So this is the 4D CT scan, which had 2 adenomas here. And this was right inferior, was removed by the previous surgeon. And so we did a subtotal pathectomy, 2.5 gland, because 1 gland was already removed by the surgeon. And we did a transcervical thymectomy for this patient. In MEN1 patient, incidentally, you must do a transcervical thymectomy because they have a chances of developing tumors in these thymus glands. And the IOPTH had a good fall. So patient was actually cured, although her MEN1 gene mutation was negative, which can be negative in the proven MEN1 cases. And this was the 2 adenomas that was removed. So patient was actually wrongly treated as a case of single adenoma. It was actually a case of a multiple gland disease, and that too familial MEN1. And the same situation could be a non-familial multi-gland hyperplasia, where if you do a localizing study and you get a nice light bulb sestemibi and you go in and remove that gland only, there will be failure of the surgery. The third important cause is that a second occult adenoma has been left behind by the surgeon if not localized. And usually elderly patients have more double adenomas. So that's also a cause. But now we have good localization studies, so this usually does not happen in our patients. The other important reason could be if you have inadequately removed the tissue in a case of parathyroid carcinoma, patient will continue to. But my focus today is to talk about persistent hyperpara in a benign or in a primary hyperparathyroid case. Ectopic localization, a decade back, was a cause of failure when MEB was not available. But because of MEB, we are not very nicely able to see the ectopic gland. For example, this young lady who presented with significant fractures, significant bone disease, you can see her ultrasound was negative, and maybe you can see there is nothing in the neck here, but she had a mediastinal parathyroid adenoma. So if you maybe was not available a decade back, you probably would have a failed parathyroidectomy in this case. But because of the maybe we knew that she has the adenoma in the mediastinum, and this is the CT scan. You can see the adenoma is in the thymus gland here. So this triangular structure is thymus, and this is the adenoma in the thymus gland. So we did a VATS video-assisted parathyroidectomy, and the patient was cured. So I'm just putting this case to illustrate how your MEB scan really helps you to pick up the ectopic parathyroid glands. Now, sometimes the parathyroid adenoma is inadequately excised. You may get cases where the parathyroid part of adenoma is removed. Obviously, this would not happen in the hands of an experienced surgeon, but inexperienced or occasional parathyroid surgeons may cause this problem. So, example, this 50-year-old lady, she actually came to me from Jaipur, where, if you look at her histopathology, she was a diagnosed case of hyperparathyroidism. The surgeon went in and removed the parathyroid. And these are the findings. Very nice notes. 2.5 centimeter firm mass located behind the thyroid. And under general anesthesia, explode everything. And 2.5 centimeter mass was removed. Now look at the histopathology. There is no parathyroid tissue at all. It's just hyperplastic nodule, which was labeled as parathyroid gland, was actually an hyperplastic thyroid nodule. So there is no parathyroid tissue in the pathological specimen, So we did a MEB scan. You can see a very large mass here. And we did a choline PET scan, which localized the left parathyroid adenoma, and also the 4D CT scan. So this is the arterial enhancement. You will see the large parathyroid adenoma, and this is the venous washout from the adenoma. And this is, such a large adenoma was actually missed by the surgeon. And the reason is because it was lying paraesophageal or retroesophageal. This is a very difficult location. And most adenomas which are missed, even the experienced surgeons, are because of this location. You see such a large, this is the thyroid, and this is the large parathyroid that was missed, weighing more than 9 grams. So it's difficult to imagine how anybody who's explored the neck can miss such a, but because if you don't mobilize the thyroid, if you don't see this area, you would actually miss the parathyroid gland. Failed non-operative method. In today's time, you see a lot of non-operative techniques for thyroid, and even microwave ablation and RFAs, alcohol injections are being used for parathyroid surgery. So this was a young boy who came to me from Delhi, and he had his alcohol ablation injected. It was a diagnosed case of hyperpara. SESTIMI scan was done and all that. And he had an alcoholic ablation done. But unfortunately, the PTH and calcium did not fall. And he was then referred for us. And we did all the localization studies. It was suggestive of a left inferior parathyroid adenoma. And we did a focused parathyroidectomy. It's a good curative fall in IOPTH. And the patient was cured. So even these non-operative methods, which look very, attractive and tempting, can sometimes result in failure if the surgeon is not really, or the radiologist has not done a good job. So these are the different causes, but again, just to emphasize, the commonest cause is the failure to remove the adenoma in the normal location. So please remember that. Now the second segment is, can we predict which patients are likely to have a failure, And this is a very interesting study where they found that age more than 70 years, obesity and ASA grade 3 were actually factors which can lead to. So if you have a very obese patient, the surgery becomes a bit challenging. And the second aspect is the fall in PTH is rather slow. So if your IPTH may actually fail in these patients, So from a surgical standpoint, we also, the obese patients are likely to fail. And ASA class, as a higher the ASA class, the likelihood of failure of parathyroidectomy. So these are some of the predictive factors. And of course, the type of surgeon is also very important. And this is again an interesting study by Shen, where he found that the high volume surgeons, the incidence of operative failure is much low as compared to low volume. And arbitrarily, they have kept 50 parathyroid surgeries in a week. So if a center is doing, or a surgeon is doing more than 50, then it's a high volume center or high volume surgeon, and less than that is a low volume surgeon. Now, can we prevent the persistent or recurrent hyperparathyroidism? We know the causes, we know we can predict to a certain extent, but can we prevent these failures? Well, first thing is operate only on biochemically confirmed HPT. I've seen patients being operated for BFHH where there is benign idiopathic hypercalcemia. That's not a surgical case, and so unless you have a confirmed diagnosis, don't operate on these cases. If you're planning a focused parathyroidectomy, localization is mandatory. And you have to have a concordant localization. And the definition of concordant is they should be concordant for three things: the side, the site, and the number. So the side, whether left or right, whether it's superior or inferior, and a single. So unless these three criteria are met, you can't do a focused parathyroidectomy. So concordant definition is very important to remember. All these three things make the studies concordant. Then, if ultrasound and maybe a negative, always go for some, as Abhishek mentioned, for 40 CTs and choline and PET scans. And if any of these studies are discordant, go for bilateral exploration. IPTS does help to prevent your failures, and in my practice, I always use IPTS, and I would recommend that IPTH will definitely reduce your failures. Mobilize the thyroid completely to reach the posterior aspect. That is very point, and I cannot really overemphasize. It's a very, very important point. Unless you open up the fascia, the parathyroid adenoma will not pop out. So that's very important. Mobilize the thyroid completely. Don't feel shy of not mobilizing. Just like a thyroidectomy, you have to really mobilize it. And then, especially the superior parathyroid glands are very difficult to actually see because they're very posterior, very high up. And unless you have really mobilized the thyroid gland, you will not be able to see. And it's not surprising that even 2 centimeter adenomas are missed because they are underneath the fascia, they are behind the thyroid gland. And if you have not done these techniques, you will actually not see the parathyroid adenoma. There are certain troubleshooting algorithms if you don't find the parathyroid exploration, but this was true when the MEBs and 40 CTs were not available. And as it was mentioned, the parathyroid glands, the success of parathyroid surgery lies in the ability of the surgeon to know a parathyroid gland when he sees. The distribution of glands is very important, and the technique, of course, one has to be very delicate. We all are aware of this. The important thing is for a missed superior gland, suppose you are not able to find the superior gland, look inferior to the inferior gland because the gland would have actually descended down. So descended superior parathyroid gland. And for a missed inferior gland, you look superior to the superior gland. That is very important. So these are kind of just tips and tricks to look for. So this is the migration you see. The inferior parathyroid glands can be anywhere from the mediastinum to the base of the skull. And this is unlike the superior ones, which have a very limited area of distribution. The inferior parathyroid glands can be anywhere. So that's, you have to really know where they can hide. So this is just a drawing to show that they could be intrathyroidal, they could be high cervical. Of course, intrathymic, we know they could be in the anterior mediastinum. Sometimes in the aortopulmonary window, these are very difficult areas for the surgeons, or they are in the posterior mediastinum. As I mentioned, the paraesophageal, these are very, very difficult areas. And even the ultrasonologists may not be able to pick up. So intraoperatively, always put your finger and see if they are lying near the, and always open up the carotid sheath if you are unable to find the parathyroid adenoma. So just explore the retropharyngeal area and the retroesophageal area. That is very important. Now, despite everything, you get a situation where the parathyroid surgery has failed or patient has been referred by some other surgeon who is unable to treat the patient. What is the road ahead for these patients? Foremost thing is confirm the biochemical diagnosis. As I mentioned, always confirm with your PTH and with your 24-unit excretion to rule out non-surgical entities. That is very important. Review the family history. Go back and see whether the patient belongs to an MEN1 family or MEN2 family. That is very important. There are always some telltale signs, some family history. So the straight answer is you ask, you have siblings, do they have renal disease? Renal stone disease? That's the simplest question. And interestingly, they will say, yes, हमारे तीनों भाई बहन में we had problems with renal stones. So that should click in your mind that you are dealing with a familial disease. So, and if the patient has a jaw tumor, so jaw tumor syndrome has to be ruled out. So family history has to be, any case of hyperpara less than 40 years, you should rule out familial disease. That's very important. So good history and good examination. In MEN patients, one patient will get small cholangiomas. These are very small skin lesions, but they are very typical of MEN1. Or if you get capillary spots or neurofibromas, that's a pointer towards the MEN2A. So our good old history and examination still holds very true for these patients. Review all the data, review all the notes. You see how interesting notes. And the trick is that if the failure is because of an experienced surgeon, then you look at the pathology. If the failure is by an inexperienced surgeon, look at the notes, and that will tell you, where the adenoma has been left behind. And you make an hypothesis whether it's a case of a missed adenoma, whether it's a case of an occult adenoma, or whether it's an inadequately treated multi-client. So after all these review, you make your hypothesis. What is the likely scenario for you? Because you are going in again. This time you have to do a complete job. There won't be a third chance. So always review these reports and make an hypothesis. Always perform the imaging studies. This is very important because it gives you a roadmap to guide the surgeon. Even if MEB has been done before, it may not have been interpreted correctly. So look at the MEB images, or it may not have been done correctly. And I have seen patients where the MEB has been done by injecting only 5 to 10 whatever the is there a nuclear physician? Yeah, 5 to 10 millivectorel or whatever is given. At least 20 should be given for a MEB scan. So always look and read the MEB report whether it has been done correctly or not. Sometimes I have asked my nuclear physician to review the image, and he would say the adenoma is here. So review the previous MEB and you can repeat the MEB also. So these are the non-invasive techniques that you do. You get an ultrasound, you repeat the MEB scan. You can do an MRI dynamic scans, or you do a 4D CT. 4D CT is now, at least in my practice, one of the commonest investigation that I do. In fact, sometimes I don't go to MEB and straight away go to 4D CT scans, because now the diffusion images have been done away with, so radiation exposure is not so much. And as Abhishek talked about methionine and choline PET, but there's a very interesting new kid on the block. This is a trihexane PET CT, and this is in fact more sensitive than the choline scan, and perhaps this is going to become the investigation of choice as far as the PET CT is concerned. And then you have the invasive tests like the US guided aspiration FNAC, arteriography, and selective venous sampling for PTH. So just to recapitulate the sensitivity in a redo surgery, the ultrasound in a redo patient, the sensitivity is very low. Again, the sensitivity of sensitivity is also low. But important thing is that in one of the series of surgical failures, 12% of patients, the adenoma could be picked up. So even in a redo study, it should be performed regardless of the initial results. Again, to emphasize, even if the MEB has been done, please do and repeat the MEB with the adequate and the standard protocols, and you may pick up adenoma in more than 10% of cases, which was missed in the previous MEB scan. 4D CT, as I mentioned, is a very effective method, and the sensitivity of 4D CT is much higher than the ultrasound and the MEB scan, And so it is the investigation of choice, unless the patient has a compromised renal function where you cannot do a 4D CT scan. This is just a representative image of one of our patient. You see it is the early arterial, very nicely the adenoma is lit up. This is the late arterial where there's washout has started to take place, and this is the venous phase where the washout has occurred. So there is a washout, arterial enhancement and the washout. So this 4D CT is a very, very good investigation, and I think you should use it more and more in your practice, especially for your redo practice, but even for your primary patient. Single investigation, it is both functional and anatomical. So you need not do an ultrasound and a MEB scan. Perhaps you can straight away go to 4D CT, and single investigation gives you both functional and anatomical imaging. PET CT I already mentioned, but just to talk about this new trihexane PET CT, it has been seen that in one series, as compared to MEB scan, they identified more lesions. And not only that, the 3 patients who underwent choline PET scan, no lesions were detected, but with this newer scan, they identified the parathyroid in 2 of these patients. So I think I met a nuclear specialist from Bangalore only, and he said he used this in 10 patients, and in all 10 patients, it correctly localized the adenoma. So this is the new PET CT that is coming out. I'll skip this. Role of venous sampling is limited. I've used only in one patient. who had an adenoma in the outer pulmonary window, and there our radiologist did the selective venous sampling. But it's very, very invasive, and you don't really need it in view of your 4D CTs and maybe scans.